Hello, Dr. Hall here. I hope you will enjoy this recorded guided lecture for pediatric oncological disorders. The objectives we're trying to take a look at in this slide presentation include the following. Explain the differences between pediatric and adult cancers. Identify and differentiate between signs and symptoms of various types of pediatric cancer. Discuss those adverse effects of treatment for cancer. Identify signs and symptoms of oncological emergencies. Describe the psychological impact of a pediatric cancer diagnosis on the family. Prepare a developmentally appropriate teaching plan for children diagnosed with cancer and for their families, and plan nursing care interventions for the child undergoing chemotherapy treatment. As always, we will take a look at growth and development of the child, and at the end, should be able to create a nursing care plan for each of the oncologic disorders. Okay, so here we go. We have some very basic principles here to take a look at and see what the differences are between adult and pediatric oncologic principles. Now, I can say the word cancer every time we talk about oncological, but it does, for the first part of this presentation, it will keep us thinking about genetics and the origination of cancer growth in children, which comes from their embryonic phase, not environmental issues like for adults. So prototype oncogenes, those genes in the body that would grow or promote having a mutation and cancer grow, occur. They can mutate to form oncogenes, which create unchecked cellular growth and resulting in a malignancy. Tumor suppressor genes involved in cell growth and death occur. That is called apoptosis, and so we're talking about all cancers here. Neoplasm is a result from uncontrolled regulation of tumor suppression cells, so we get a malignancy or we get a benign tumor, which benign just means that it won't metastasize and does not contain oncocells. Process of oncogenesis is the same in children and adults, and some genetic mutations may contribute to cancer development. There's a lot going on in this slide, so I hope you will just stop the recording for a minute, take a pause, make this slide big enough to take a look at, because you're getting a description here of the differences between childhood cancer and adult cancer. And for example, I already just mentioned that most childhood cancer comes from an embryonic mishap rather than from environmental issues. So all of the devastating cancer disorders that are present in infants and children that we'll talk about in this slide presentation have originated most likely from some mishap in embryonic phase. And we don't have a good reason for why those cancers occur in childhood. And again, please stop and enlarge the slide and take a look at it. So is the following statement true or false? Childhood cancer is less responsive to treatment than adult cancer. This comes from the slide I just asked you to take a quick look at. So if you took a quick look, you can probably answer this. False. Childhood cancer is more responsive to treatment than adult cancer. Childhood cancer is also more likely to affect tissues and bone marrow components. In contrast, adult cancers are more likely to affect solid organs. General nursing interventions for the treatment of cancer. We take a multidisciplinary approach. We try to incorporate growth and development principles. We get a team together, nutritionists, a child life specialist, psychologists, the etc. here are the doctor, the nurse, physical therapy, occupational therapy, We do long-term follow-up on physical morbidity, mishaps that happen, psychological morbidity, and then looking at clinical trials to increase effectiveness in getting cancer. So one of the treatments for cancer is always a consideration for chemotherapy. It doesn't mean that all cancers can receive chemotherapy or all patients can receive chemotherapy, but it is a consideration. And chemo, as you may already know, can be intravenous, oral, or intrathecal. We usually use a central venous access. You don't want to extravasate chemotherapy into a peripheral IV. When that occurs, you risk losing a limb below the extravasation or the chemotherapy getting out of the inside of our blood vessels and into the tissues. We ensure safe handling and administration in your practice of nursing. You cannot handle chemotherapy without some additional training. Works in relation to the cell cycle. Dosing is based on body surface area. So we do use a nomogram to determine the body surface area and use a formula if the nomogram is not available. We always monitor for side effects and intervene appropriately. So what are the side effects? We monitor for infection, high risk due to myelosuppression. We're going to monitor lab work for white blood cell counts. Neutropenic precautions, administer granulocyte colony stimulating factor, manage anemia, red blood cell count suppression, encourage iron consumption, administer blood transfusions and epoetin alpha. Coming from our hematological discussion there. Prevent hemorrhage, platelet suppression, monitor for signs and symptoms of internal bleeding, avoid high impact activities, and then for us, we want to avoid rectal temperature assessments, medication administration, and other procedures that impact chemo. Manage nausea and vomiting, giving antiemetics before the infusion and around the clock for 24 to 48 hours. Non-pharmacological therapies like ginger root and peppermint oil, acupuncture, unless they have anemia, craniosacral therapy, cluster nursing care to minimize interruptions. We want to promote pain relief, administer medications for painful procedures, provide non-pharmacological interventions. And when we say that, we're talking about things like positioning, pillows, soothing music, visual imagery, maintain adequate nutrition, treat mucositis, consult dietitian for diet recommendations, and they may have food aversions associated with the changes in taste and sometimes a tinny aftertaste after chemotherapy. And I want to pause and just say that mucositis is an infection inflammation in the oral cavity or anywhere in the GI system. So, our alimentary canal, an old term for gastrointestinal passage, anywhere in that alimentary canal, there could be mucositis. So esophagus, stomach, bowel, small bowel, large bowel, colon, rectum, any of those. Side effects we want to promote growth and development, so provide those opportunities for social interaction, encourage participation in typical daily routines when it's possible and it's safe. Provide education, even in the hospital, if kid comes in for prolonged chemotherapy or prolonged cancer treatment. We usually have in the bigger facilities, so University of Iowa would probably be the nearest place to us, there's a school. So the schools go out and collect textbooks and resources from whatever school the child is in, and they actually hire teachers to teach them while they're in school. Provide emotional and psychosocial support here. Describe the effects on body image, allow expression of feelings, refer to support groups, refer to social workers and counselors. We have this group of wonderful people in pediatrics called child life specialists, and we also have these wonderful people called recreation therapists, and their whole goal is to keep a smile on a child's face and to present them with something distracting and supportive. So alopecia would most affect the body image of a child from which development stage? And you have to know what alopecia is. Toddlers, preschool, school age, or adolescent. It's adolescent. Although school-age children and adolescents are likely to experience body image issues related to losing your hair, adolescents are more susceptible to pure thoughts and opinions. Therefore, adolescents would experience greater distress than school-age children. So the next therapy here to talk about is radiation therapy. Again, this is a standard conversation for any cancer discussion, so you may have some supportive information in your adult health class. Kills malignant cells and normal squamous cells surrounding the radiation site. We have to assess daily for redness, scaliness, and breakdown. The skin can be, so to speak, burnt, first-degree burn, in the area near where the radiation is delivered. We give targeted radiation most likely, unless we're doing brachytherapy, which are little seeds of radiation that are instilled inside the body, usually for throat cancer or cervical cancer or prostate cancer. Avoid fragrance soaps or moisturizers. Skin is more photosensitive, stay out of the sun. Use sunscreen, wear long pants and sleeves, and I would add in here, if this were my slide, floppy hats. Side effects here for radiation: nausea, vomiting, fatigue, and appetite changes. Now let's just talk about some of the emergencies associated with cancer diagnosis and cancer treatment for children and infants. Something called tumor lysis syndrome occurs. So what is that? It's actually that if you have a tumor, as we're treating it, we're breaking down the tumor, trying to kill it, trying to eradicate it, get it out of the body. But as it breaks down, it might break down rapidly, and anything that breaks down in the body causes byproducts, okay? So when we talk about these metabolic abnormalities from release of intracellular contents after malignant cells are destroyed, they collect all over the body. So remember, they travel to the spleen. That's our, workshop in the body, that and the liver that try to clean out the blood. But this metabolic syndrome that we see may result in hyperkalemia, hyperphosphatemia, hypocalcemia. Okay, so remember, calcium goes down, potassium up, phosphates go up, and uremic acid goes up. The only one that goes down is calcium. Why do you think that is? I can't hear you, so just think on that one. Hydrate with IV fluids before chemotherapy and treat with allopurinol. All right, so tumor lysis syndrome is one emergency, but another is just sepsis, progression of infection in children with neutropenia, meaning neutropenia is associated with lack of or low white blood cells. And so if we get an infection in our body, we expect our body to fight it with white blood cells. Absolute neutrophil counts less than 500 are at higher risk, and prevention is the key. So if a child or an infant, we find that they're neutropenic to that point, we're not going to let people come visit them except maybe the parents, and they will be in isolation. Confirm this with positive blood cultures and treat with fluid administration, antibiotics, and ventilatory support. Fluid administration, again, we're trying to increase the isotonic volume in the vascular spaces in the blood so that any of these byproducts that are out floating around, that we can capture them and get them out of the body through the kidneys. also all of our blood is circulating all through the liver and goes out through the kidneys. So if we increase the blood volume by giving isotonic fluids, then we can more likely quicker get back to homeostasis. Superior vena cava syndrome can occur, compression of the superior vena cava from some kind of mediastinal mass. When that happens, there's dyspnea, cough, headache, pleural effusion, and edema in the neck, face, and upper extremities. We treat that tumor to reduce pressure. It may require intubation, usually requires getting rid of that tumor surgically. Increased intracranial pressure can occur from primary tumor. We're going to talk about different types of cancers here in just a minute, and the neurological, cerebral cancers is something we'll talk about. Manifestations here are vomiting, vision changes, altered mental status, headaches, and behavior changes. It may result, increased intracranial pressure may result in herniation of the brainstem without prompt intervention. Now, I love talking about that because of my 40+ years in critical care, and I worked in neuroradiology, so a little story here. I know, not supposed to do that, but here you go. So do understand that our brains float in our heads in cerebral spinal fluid. So if we have increased pressure inside our head, it has nowhere to go because of the vault of the cranium. We have a big bone there on our head, around our head, that won't allow that pressure to be released. You would think maybe it would pop out your ear, but it doesn't work that way. So if the pressure increases, it forces the brain downward, and downward it will impale itself or get spiked or hit and become impaled on two bony prominences in our cervical spine that actually strike upward. So if you think about vertebrae and how they have that bony prominence on the back and how there's sort of like an upward spike on each of them, well, our C1 has two of those, and when the brain floats, it doesn't float anymore, and it rests down inside the vault of the head, it'll impale itself and then bleed, and that's called herniation. Herniates, and if herniation occurs, there's no coming back. There's also cytokine release syndrome. Multi-organ failure can occur because we have these free-floating cytokines. Sepsis, acute respiratory distress in children undergoing immunotherapy, and we want early detection and treatment is key to survival. So how do you figure that out? So we look at multiple organ failure, and then we start doing some testing to determine cytokines or breakdown in the body. So do remember too that anytime you break down protein, you're creating an acid environment inside the body because the breakdown of protein has those free-floating elements. Stem cell transplantation is also treatment, intense chemotherapy and radiation to create myelosuppression, may be followed by infusion of stem cells. We talked in our presentation for bleeding disorders about doing a stem cell or transplant, and how we might have these hazards of rejection and myelosuppression, and how we have to give prophylactic antibiotics, antifungals, maybe immunoglobulins, and perhaps graft versus host disease, acute or chronic, which is rejection of those stem cells, can occur. And there can be growth retardation, hypothyroidism, and secondary cancers because of a stem cell transplant. Now, none of us want to talk about kids or infants that die. And during our course, we're going to pause in class for our 1 hour and talk about St. Jude's, because they are the premier hospital, premier treatment center for childhood cancer within the United States. Early palliative care can mitigate suffering and promote symptom management. So some cancer diagnoses have a 100% death. So when we know that, we have to make some plan, right? That's not good news to share with anybody, especially parents and family or the kid. So we're going to look at early palliative care to keep them comfortable. Hospice care if death is imminent. For kids, there's always the priority of quality versus quantity of life. Okay, so they're starting out in life, they're little, we know that they're not going to have a long life. And so what can we give them that's kind and humane, and that is quality of life. Now, a lot of the kids in my practice have shown us what their quality of life needs to be, okay? So it might be getting up every morning and putting on a Spider-Man uniform, or it might be sporting a blue cape, a Batman cape, every day. Or it might be being visited by their favorite football, basketball, or hockey player, or Make-A-Wish Foundation, something that they've always wanted that will just make them so happy that they can't forget that wonderful experience. Pain management is the most important intervention for hospice. We explain pain management regimen to the families and provide emotional support, and ensure siblings are involved and provide age-appropriate explanations. Also, age-appropriate and sibling genetic counseling too. So, and we refer families and children to support groups. Again, we have these wonderful child life specialists. I didn't mention chaplains, but in a pediatric unit, in a pediatric hospital, let me say, there are pediatric chaplains that come and play and visit with kids. Everybody I wish you could see what a university pediatric hospital looks like. Go to Peoria and just walk through the halls at their pediatric hospital, Peoria, Illinois, or go to University of Iowa and walk through the pediatric halls there. You can, make an independent appointment to just be shown by a volunteer what all the hospital's about. All of the children's hospitals love to have people look at them because they are funded by good and kind people for all of this terribly expensive care that children need if they have cancer or devastating illness. Anyway, I wish you could see that. So I'll tell you again just a quick story from my background. It was not uncommon at the University of North Carolina in Chapel Hill, North Carolina, for you to be walking down the hall needing to use the elevator, and the elevator opens and there's a patient care tech, some young man that's probably in medical school but employed as a patient care tech or a scribe, and they've got one of the little kids in there with a Corpac tube and an NG tube or a belly tube and an IV pole, and they were playing ball in there. They were, bouncing the ball off the walls of the elevator and seeing how funny it would be to watch people as they get on the elevator be surprised that they're in there. So all kinds of things can happen in that whole environment to make the children happy. So our first disorder here is acute lymphoblastic leukemia, ALL. It is the most common form of cancer in children in the United States. Immature, non-functioning white blood cells or lymphoblasts dominate bone marrow production. They're not mature enough to do their job. Red blood cells and platelet suppression from white blood cell production. Symptoms are fatigue, pallor, fever, anorexia, and petechiae. Okay, so notice that those symptoms look like a whole lot of other things. So at the very beginning, it's hard to diagnose ALL just based on symptoms. There are 3 phases of chemotherapy in treatment: the induction phase, consolidation phase, and the maintenance phase. And you can read some details here. We want to ensure that pain management is provided for all procedures. AML, or acute I can say that word when I want to. AML, does not respond to treatment as well as ALL. Intense chemotherapy regimens that cause prolonged bone marrow suppression may require bone marrow or stem cell transplants. Excessive number of myeloblasts, so different from ALL. Symptoms similar to ALL with subcutaneous nodules or chloromas. Treatment similar, and we focus on preventing and treating chemotherapy side effects due to these intense. Hodgkin's lymphoma also impacts adults, but in the pediatric population it is characterized by the presence of what we call Reed-Sternberg or RS cells, beta lymphocytes that have lost immune function. Typically starts with lymph nodes and spreads through lymph system. Now, just a word, remember with children and infants, it's usually an embryonic problem to get Hodgkin's, but an environmental problem for an adult. Symptoms are swollen, painless, and rubbery lymph nodes in the cervical and supraclavicular region, fever, night sweats, cough and dyspnea indicate mediastinal mass. We stage Hodgkin's based on the spread of the disease, and you'll find that in the textbook, the different stages of Hodgkin's. We treat with a combination of chemotherapy and low-dose radiation. Then there's non-Hodgkin lymphoma, uncontrolled proliferation of abnormal lymphocytes, so different cell. It's common in adolescents, age 15 to 19. 4 major subtypes, further divided on basis of cell origin and antigens present on cellular surface. Symptoms very similar. You do see tumors outside of the lymph system, fever, weight loss, night sweats. The subtype of cell origin has a little bit of different presentation for each. Increased chance for oncological emergencies, and chemotherapy regimen depends on the subtype. So here we have brain tumors, so we're going to see a picture of these in just a minute, and there are many names for these in many different places, so I'm going to try to point those out when we look at the picture, what we're looking at there and what you might experience. Well, not you, but our patient. So we can have benign brain tumors, but there's still a problem, right? Because they're moving the brain tissue to the side and causing increased intracranial pressure. Okay, or they can be malignant. They're aggressive. They don't really have a border. They can just be all through the brain or consolidated. And here's some names of our brain tumors: an ependymoma, a pituitary tumor, medulloblastoma, pilocytic astrocytoma, glioblastoma, which is not talked about in this slide presentation, is fairly popular in the childhood population and infants, and it's deadly. Symptoms vary based on where the tumor is. I mentioned the increased intracranial pressure. There can be headaches, ataxia, so inability to walk without looking like you're dizzy or going to fall. Behavioral changes, memory loss, vision changes. Treatment depends on the type, size, and location of the tumor, but can include all of those we've talked about. Only certain chemotherapy agents cross the blood-brain barrier. So I don't know if you've had the neuro lecture in adult health about the blood-brain barrier, but it is just what they're saying here, that not everything goes across when the circulation, when the blood gets in the brain. Only certain elements in the circulation are allowed into the brain. Does that make any sense? There's sort of like a gate in the blood-brain barrier. It's not a spot in the brain where you could see a gate, but it's just once you force the blood up into the brain, it can't all get in there, or all the elements of the blood. So you do know that when we take a medication, it is disseminated throughout the body through the blood, okay? Provide pre-op and post-op care, monitor for increased intracranial pressure, definitely. So here's our picture. Again, I would encourage you to pause this recording and just take a quicker look at this. So you notice that, I have over 50 years of nursing experience and I can't pronounce everything that I come across. It's kind of comical. I was one of those students back in the day that when it came to pharmacology, I wasn't worried about giving medications or about knowing what I needed to know about them. I was mortified that the teacher would make me say the name of the drug. And so because nobody really did, I had my drug cards, so I tried to learn the best I could. And the teachers, I noticed, weren't saying the name of the drugs either. So funny that I'm in that same spot here today. But anyway, don't worry about that, okay? Try to pick apart the drug names. You'll have some really good pharmacology courses while you're here, and we will try to help you move through that by looking at the prefix or the suffix and sorting all of that out, okay? But brain tumors, for me, are fairly easy to talk about and fairly easy to pronounce because I've had probably the most work in my career in working with neuro. And so this picture, back to the picture, just notice that the ones that are listed here are trying to help you see that there are common tumors for different places in the brain. Okay, so if it's involving the cerebellar, it's an astrocytoma in the cerebellar region, so the one over on the left of the bottom. What does our cerebellum do? Okay, well, it helps us with balance. So if you have a tumor there, definitely going to be a patient, a little kid that's ataxic. They're not going to walk very well. And that might be the first sign that a parent has. Maybe it's a 3-year-old child, and all of a sudden they just look like they can't put one foot in front of the other. Okay. And then, for example, there's nothing really pointing to the red part here, which is the where our cerebrospinal fluid is. It's called a cistern. Just like on your house, you have a cistern where water collects. So this is where our fluid is. That is originated. It grows there, and it bathes our brain and our whole spinal column. So you can have a tumor that's in there, and it can grow pretty big because it's kind of an open space rather than pushing the brain aside. And that's where glios show up. And then we're talking about, let's see, brainstem glioma down here, the one on the bottom. So what does your brainstem do? Your brainstem keeps you awake or puts you to sleep. There's something in there called the reticular activating system that notices when we're awake and when we're asleep, and it regulates our body depending on what's going on there. And as you look around, the brain, it's talking at the top about cerebral tumors. That's kind of a think out because they have their own names too. But notice if you have a cerebral tumor that's in your frontal lobe, then inhibition is going to be an issue for you. So you may not notice that there's hot water. The kid may not notice that the water's too hot. So we have to be paying attention to that. If I have a temporal lobe, hearing is impacted. If I have an occipital lobe, vision is impacted. So that's what I want to say about brain tumors. The symptoms go along with where they're growing, and it depends on where they're growing, how quickly we can recognize that they're there and then treat them and take care of them. So I encourage you to just sort of pause on this slide and sort of take that in. Okay, so let's talk about a few of them. A neuroblastoma arises from embryonic cells of peripheral nervous system. It's typically found in children younger than 5 years, can occur anywhere in the sympathetic nervous system, but most common in the medulla and adrenal gland. Manifestations depend on the tumor size tumor site and extent, may only have asymptomatic swelling. Staging is based on the spread and characteristics, and there are some good charts on staging in your textbook. Treatment depends on stage and may include surgery, radiation, or chemo, may use biologic therapy or immunotherapy. So here's a great picture of neuroblastoma and where it can occur in the body. Again, a time to pause and just take in the picture. Then we have Wilms tumor, which is a nephroblastoma. Nephro refers to kidney. May have metastasis to the lungs, brain, bones, and lymph nodes. Is typically asymptomatic at diagnosis, just an abdominal mass, and then we have to get in there and do biopsy and find out what it is. Do not palpate the abdomen if Wilms tumor is suspected or confirmed, because you can rupture the tumor, then it would seed and metastasize. Very, very important. Staging is also noted in your textbook. We treat it with a nephrectomy, chemotherapy, or radiation. So if a kid is diagnosed with a Wilms tumor, they're headed to surgery to get rid of it. When assessing a child with Wilms tumor, which part of the assessment should the nurse avoid? Hint, hint, belly. Yes, palpation. The nurse should avoid palpating the abdomen of a child with a Wilms tumor. Wilms tumors rupture easily, resulting in seeding and metastasizing within the body. So let's talk about an eye tumor, retinoblastoma. Okay, it's in your head, so it's a cerebral tumor. It's a malignant tumor involving the retina. It can be inherited or sporadic. It can be one eye or both eyes. They look like they have the cat's eye reflex, strabismus, where the eyes sort of wobble in place, vision loss, orbital inflammation, and proptosis, meaning that you can't keep your eyelids open. Treatment depends on size and location of the tumor. The goal is to preserve the eye, preserve vision. And then we have osteosarcoma. Sorry about that. I'm going to go back. It's like, nope. Well, we'll move on here. Sorry about that. I kind of blipped. And I'm 37 minutes into this, so let's keep going. Osteosarcoma is cancer of the bone and usually attacks adolescents during the growth spurt. So again, there could be an embryonic latent mishap in the body, and then it just comes about here. Most commonly occurs near the growth plate of the long bones. There's pain, soft tissue swelling, kids will limp, and there could be a pathologic fracture there, like an osteoporosis. Further assess any orthopedic pain or injury. May do chemotherapy, followed by surgical resection of the tumor, and if can't do that, then amputation would be one way to control a sarcoma. Ewing sarcoma is much more intense treatment than osteosarcoma. Typically presents in adolescents but can occur in children younger than 10 years old. And usually it's in the diaphysis of the long bones, the pelvis, the spine, and the chest wall. It's similar to osteo, but with weight loss, fever, and fatigue. So hard to determine, need to do some biopsy and get some information. Again, may require amputation, and we want the patient to avoid weight bearing until the treatment is complete. Rhabdomyosarcoma. These are rising from muscle tissue, rhabdo meaning muscle, or I'm sorry, myo meaning muscle. Most common in the head and neck or genitourinary tracts, extremities, and orbits. Peak incidence in children younger than 10 years of age. Clinical manifestation depends on the tumor sites. Staging based on site, size, and spread. Treatments based on stage, histology, and ability for the tumor to be resected. Typical treatment includes the number 3, surgery, chemotherapy, and so there we have oncological disorders for our pediatric population. I hope this has in some way been helpful, and it is almost a 40 minute presentation, but it's a good one. Enjoy.